Good evening. I'm, just in case folks are wondering, I'm not Ellen Nolte. She'll be up here shortly. I'm Stanley Brown. I'm the Dean of the Dalai Lama School of Public Health, and I want to welcome you all to the very first Boehm Lecture. And I'm thrilled to see a lot of friends and family from the school here, people who have been leaders in our system, and I'm excited about tonight's topic. But before we start, I want to acknowledge the land on which the university sits today. For thousands of years, it's been the traditional land of Indigenous people and remains the home today for Indigenous peoples from across Turtle Island. We're grateful to have the opportunity to work on this land. Now, let's turn to tonight's topic, leading edge options to integrate care. Virtually every system is working to integrate care right now, with variable success. But it is what patients want. It does produce better quality. It can produce better cost, and it gives the vehicle for integration and coordination with social services and social care. Tonight, we'll have the opportunity to discuss and debate and explore leading edge options to integrate care with our faculty and with health system leaders. Later, we'll hear from an economist, a health services researcher, a hospital CEO, and a mayor. And I have only 4 quick and pleasant tasks before we start tonight's work. The first is to acknowledge Les Boehm. Where's Les? Great. It's Les's vision that actually created the Boehm Lecture. And so some folks will know Les as one of our faculty. They'll know him as a champion of innovation. They'll know him as a keen historian. And for folks who may have seen him in various media outlets over the last little while, they'll know him as a thoughtful commentator on health and our healthcare system. But Les had the vision that we can create opportunities to engage all of our communities and engage all of our communities in discussions about the health and healthcare system that we want, and I think that we feel that we deserve. And so I'm really grateful to Les for his vision and to his gift. So thank you, Les. My second task is to introduce Helen Angus. Often when introducing someone like Helen, I say that if you don't know her, that's your problem, not hers. But I should do a little bit more tonight. Helen is the Deputy Minister of Health right now. She's been a Deputy Minister in other portfolios within government. She's been a leader across a number of health sector agencies. And she's been the architect of a number of very profound changes to some of our systems of care already. I'm happy to say she's a friend and a number of years ago, a co-author as well. Third, for those of you who are tweeting tonight or doing other interesting things on social media, at least related to the talks tonight, the hashtags are Boehm Lecture and Aunt Health. And finally, it gives me a lot of pleasure to introduce tonight's keynote speaker, Professor Ellen Nolte. She's a professor at the London School of Hygiene and Tropical Medicine. She's the former head of the London hub of the European Observatory and of the RAND Europe program on health and healthcare. And most helpfully for us tonight, she's an internationally recognized expert in health systems and systems of care and their improvement. And Dr. Nolte, I know it's my and everyone's pleasure to welcome you here tonight. Thank you. That should all work seamlessly, and if not, just a panic when I'll come up, okay?
Thank you. Thank you so much. It's a great honor to be here today and to give tonight's lecture. It's quite humbling actually to stand in front of this massive audience. I've started my title with a hopefully not too rhetorical question. What I'm going to do today is to really talk a little bit about why we are here in terms of talking about integrated care, the underlying challenges, and then share with you some of the insights of work we've been doing in Europe, in particular around integrated care, and some of the impacts that we have, or we're trying to understand, we might see from integration, and then come to some concluding remarks about where we should be going. So what are the challenges? I think the key underlying issue, or perhaps achievement, which we often forget when we talk about problems in healthcare, is that actually we have made huge progress over the last decades or so to improve population health, as measured, for example, by increasing life expectancy worldwide. What we do see is that there has been substantial variation in the relative improvements within and between countries. And these are some recent data from the Institute for Health Metrics in Seattle, which looked at the Healthcare Quality and Access Index. And this particular slide shows you the gap into what countries should have achieved in terms of outcomes in relation to healthcare access and quality, and what they actually did achieve given their developmental level. And what you see here is the bluish, purplish colors are those countries that have done a good job, if you like, and the reddish, orangey colors where there is substantial distance between what could have been achieved and what has been achieved. Now, for many of you, these figures are perhaps not surprising, but they reiterate and reinforce that there is substantial global inequality in terms of what healthcare can achieve. All countries globally are addressing or struggling with the same issue, which is the rising burden of chronic disease, which is partly because we have become much better in helping people to survive with long-term conditions. Diabetes is one example, HIV/AIDS is another example, and people now survive with cancer rather than dying from it, at least for some cancers. So we have a changing demographic around the burden of disease, but also partly as a result of this, an aging population, and by virtue of being older, being also exposed for longer to chronic disease risk factors. So we have this increasing burden. And these are just some recent data from Europe, where about 1/3 of the European population, or the population in the European Union, reports at least one chronic condition. And what you can see here is substantial variation between 20% in Bulgaria and Romania up to 40% in Finland and Estonia, but highlighting the burden, which is not, of course, only limited to Europe. These are some really interesting data from Ontario, which were published last year, showing that about 25% of the adult population report at least 2 or more chronic diseases. And these 25% account for about 2/3 of the health system expenditure. And this is fairly generalizable to other populations, at least in high developed countries. What is interesting about this study is it found a very clear dose-response relationship between the number of conditions and the healthcare costs, both at younger ages and at older ages. And this study also highlighted, and again, these are data which we also find in Scotland and Denmark, particular pockets of a high burden of multimorbidity, in particular physical and mental health conditions among marginalized populations, and the related costs. So we do have a challenge here, how to address it effectively. That's the question. And I think it is a problem simply because the way the health system is organized at present. And I always find this slide from Holman and Lorick quite informative, because it really challenges, or it really illuminates, for me at least, why countries find it difficult. So on the left-hand side, we have the characteristics of acute disease, which very much really still characterize how most systems are organized, the acute episodic model of care. And on the right-hand side, we see what chronic illnesses actually mean for health system responses. So these conditions don't go away. We often don't know what works best. We often see adverse effects, especially if you think about people with multiple conditions and polypharmacy. And most importantly, people with chronic conditions live with their condition or their conditions 365 days a year. Part of this time they spend with the health service, but most of the time they don't. So they do have a very important knowledge that needs to be shared with professionals and providers in order to improve outcomes. So what systems really need to be moving towards is a complex response which extends over a very long period of time, bringing together different professionals in different compositions over different periods to meet the changing needs of people with chronic conditions, and that actively engage patients. Now, in reality, this is not what happens. This is a slide or an illustration of a patient with multiple conditions in England, and on the right-hand side we find another one. And this really illustrates the various ways patients have to organize their own care in order to get the treatment and services they need for the various conditions they're facing. So it's really left to the patient to coordinate their own care, to the maze of different providers along the way, which causes challenges and inefficiencies, of course, but also tremendous burden for patients who are affected. And indeed, lack of coordination is something which patients do report on, and these are data from the Commonwealth Fund survey from 2016, looking at the proportions of adults in the various countries that have reported a coordination problem. On the left-hand side, you see problems in primary care mostly, but most concertingly is on the right-hand side, this high proportions of people who report problems in coordination, who have been hospitalized, up to 60% in some of the countries that have been surveyed. And we do know from the evidence that poor discharge planning typically leads to higher risk of readmissions, of emergency readmissions, which of course is an inefficient use of resources and also not much fun for people affected. I've also mentioned the need to really engage service user in their own care, and this is again data from the Commonwealth Fund highlighting the challenges here. Even though systems are becoming better and actively engaging their patients by talking about treatment goals, by talking about treatment options and the way they would like to be involved, countries do vary by between 20% in Australia up to 40 or 50% even in Sweden, where this is not really happening in routine care as yet. So in addition to the burden or the challenge in relation to how to best respond to the rising burden of chronic condition, there are other issues, of course, as well. So medical technology advances rapidly. Precision medicine is a new hype, as I've learned at a meeting last week at the European Commission, because there's lots of industry interest, of course, involved, but it comes with a price tag, and we have to ensure that these new technology actually do provide value for money. We have changing expectations in the population, partly because more information is available, but patients are also forming more important networks and movements, such as patients like me, to really share experiences and get information, which is not easily to come by usually from the traditional system. Most countries also do face the perennial problem of continuing health inequalities and inequities in access to healthcare, an issue which does seem to be increasing in a number of countries as well. And all of this comes against the background of increasing financial pressures on the economy and the health system as a whole. So a whole bunch of things that systems are facing and that they have to deal with, and some of these are quite contradictory to address. So what's the solution? Now, luckily we have organizations such as WHO and the OECD who've come up with ideas, namely people-centered healthcare, sometimes also referred to as patient-centered care or person-centered services. Most recently, the OECD Health Minister statement arguing for the need to reorient health systems to become more people-centered. Now, what does that mean? WHO, in its 2016 resolution, has identified a number of points why a people-centered health system is needed. It's needed to ensure equity in access. It's needed to ensure quality in the services rendered. It's needed to provide responsive and participatory care. It's needed to increase efficiency and to ensure resilient systems, that we are prepared for what is to come. Care coordination is at the core of some of these issues. And we've, of course, it's a topic for today as well, care coordination as a key ingredient of more integrated services. And I'm going to focus on that for the moment. Care coordination or integration, forgive me for using these two terms for the moment, at least interchangeably. There are different, although depends on who you ask really. But for the moment, I just use the terms at the same time. We do have evidence that care coordination can lead to better outcomes, at least intermediate outcomes, and improves the services, the quality of care, and patient satisfaction. And that's all great. However, the problem remains that we do not know yet what works best in what circumstances for what population and in what locations. And what is also concerning, especially for policymakers, is that the evidence that integrated care or care coordination actually does provide value for money still remains rather patchy. There are instances where we do have good evidence, but overall the evidence isn't as good as we would like it to be. But keeping that in mind and the challenges systems are facing, of course, countries are experimenting with new ways of providing services. Ontario, of course, does so as well. What I'm going to do now is, for the moment, to just share with you some insights from work we've been doing in Europe over the last 10 years to understand better what countries have been doing to improve the service delivery for people with chronic conditions. And one early example of what countries have been doing is to introduce disease management programs, typically at national level. And I've just listed a number of countries here that have been doing so, looking at things like diabetes, COPD, depression, cardiovascular disease, and some cancers. And although in all of these countries, these models of care are called disease management, they're actually quite diverse in terms of what they would like to achieve, and also how these models work, so whether, for example, they use nurses or not. And the use of nurse in primary care has become a real policy hit in European settings. And the idea, again, is to, if we kind of shift tasks from more expensive doctors to cheaper nurses, we kind of manage the conundrum of addressing the issue of expensive chronic disease. And indeed, we do find that nurse-led clinics and case management approaches are quite common in a number of countries, such as England, Sweden, the Netherlands, and Spain. And interestingly, even though nurse-led services have been on the agenda for quite some time, countries such as Germany, Austria, to a certain degree Denmark, France, are still struggling to introduce nurses into primary care for historical reasons, partly also because doctors mostly work in solo practice with very little support staff, and they find it really hard. Even though they're experimenting with lots of very interesting models, many of these are still in the experimental status and they don't really spread across. Now, there are several issues around introducing roles such as nurses into primary care in those systems that are not used to, and I believe Ontario or Canada also finds it challenging. And there are a number of issues around them. One is, of course, professional resistance, often by the medical workforce, and the lack of trust that other professions might be equally well equipped to provide services. And there's a really interesting example from Germany to that effect, which I can explain a little bit more about later today. But also with everything we do in services, as soon as we introduce a new role, someone has to pay for this. And the question is, who pays and how do we pay for that? There's also the issue about legal challenges and regulations. So in Belgium, for example, they have been struggling to introduce nurses into primary care because of the key underlying challenge of who's actually going to be the clinical responsible person and what about liability in case something goes wrong. How do we have to change workforce education and training in order to introduce these new roles? And most importantly, perhaps, a point which we see is most often forgotten. If you introduce a new role, you take away something from someone else. So how do you do that? How do you get people to give up tasks that they have performed previously? And how do you make sure to not cause friction? And we have a really interesting example from England where this has happened when they introduced the so-called community matron in 2004. And again, I can say a little bit more about that later on. And finally, often, introducing new roles is seen as positive, but there are often also unintended consequences. So we might actually increase fragmentation rather than reduce it, simply because we have forgotten about the other roles that these people usually did and no longer do. So who's doing those roles? If you think about the professionalization of nurses, the basic nursing role still has to be done. Who does it? And in England, it's actually a really difficult challenge at the moment, who's doing the basic nursing role. But coming back to new models of care, and as I said, we've looked at the experience in Europe. And one of the questions, of course, if you change systems, how you do that. And one way of doing that is using money. So, I'm going to come back to the money in a moment and talk about something else first, which is the challenge which single disease-focused programs are facing. And of course, as I've mentioned earlier, multimorbidity is becoming more important, and some countries, at least in Europe, are increasingly recognizing that a single disease management focus is no longer appropriate. So there are experiments going on moving towards population health management models, and one example here is from the Netherlands. And what they have been doing over the last 5 years or so, they've been experimenting with these sort of regional approaches, which are highlighted here in different colors, bringing together a wide range of providers, including housing, for example, and social services, to really meet the very diverse needs of a very varied population. Sorry, this is all in Dutch, but what it essentially says here is lists the number of providers and agents and stakeholders that are involved, from the citizen to the municipality, to home care, the physician, the primary care provider, the purchasers, another organization. And what is interesting, what you can see here as well, number 1 to 9 are the different models. And the full circle means complete participation in decision making. The 3/4 circle means co-production, and the half circle means advisory role. And if you can just focus on the top line, which is the citizen, all of them involve citizens quite substantially in decision making, which I think is quite an interesting observation. And they also look not only at a specific aspect of the service delivery model, they look at a wide range from primary prevention all the way to treatment, and also looking at substitution, as well as some more fundamental changes around the data infrastructure and other things. So that's happening in the Netherlands, and the evaluation findings should come out, I think, next year. Another interesting example, at least I think for other countries, is England, because so much happens that it's actually easy to lose oversight. And I found this very useful slide. You can't read it, but it's just to illustrate what's been happening over the last 10 years around integrated care, and the various models that have been tested and tried and abundant, and others that have come in. And there is an awful lot going on. I think some of you might have come across these new care models that have been introduced from 2013-ish onwards, the so-called vanguards, which are essentially various ways of thinking about services, bringing together primary and acute care, bringing together particular providers within the community, urgent and emergency care, etc. There are also primary care home models, which are set in primary care, bringing together the various providers. And then there are the integrated care pioneers, 25 of them, bringing together health and social care. And as you can see already, it's quite crowded. And it's quite easy to lose oversight. And also there's a lot of overlap between many of these models and new ideas. So what's been happening more recently is to try to streamline all of that. And the latest one is really to move towards integrated care systems in 2018 and to really push that a bit further. Now I come back to how do you implement things, and using money is always quite useful. That's what we have found. And funding has been put aside for startup, and we've seen that in a number of countries to help these new models of care to get off the ground. And here you see some examples. But most frequently, financial incentives for payers, for typically doctors, and in some cases also for patients where this is appropriate, for example, reducing fees to use some services. More recent examples have, however, moved away from financial incentives as the only way of implementation support, but to move towards innovative payment schemes. I think many of you have heard about the bundled payments in the Netherlands and the United States. The shared savings program, the Healthy Kinzigtal in Germany, has become quite famous in selling that model, and more recent global payment models that have been trialed in the United States. So it's all great, a lot of stuff is happening, but the key question is, do they actually make any difference? And this is often quite difficult to tell, especially when you look at England. So much is going on. It's actually quite hard to find robust empirical evidence simply because who do you compare against if everything is improving? So the National Audit Office has looked at the 50 vanguards that have been trialed since 2015, and to really see what we can see. And of course, 3 years isn't a very long time, so their findings are not as impressive for now. Although the second bullet point is an interesting one. What seems to be emerging is that those areas where vanguards have been established, the rate of growth in readmission has slowed down. So it's the rate of growth rather than the actual number. But the overall impact on terms of demand for hospital services and on patient outcomes remains unclear. Now, we could argue the time is way too short to have definitive evidence on this, and more work needs to be done to understand that. But I think it's also important to understand to whom do these new models actually make a difference. Is it the system more broadly? Is it actually the patient, which you would hope? And this is data from an evaluation I was involved with a few years back when we looked at the first program of integrated care pilots from 2009 to 2011, where we found that staff really liked the new models of care, but patients didn't, because they couldn't actually access their usual carer. There were issues about care coordination. And it also highlights, and this is something which I'm going to come back to in a moment, that often these new models are being introduced without the patient in mind, which seems contradictory or counterfactual almost, given that we want to improve services for patients. What was interesting about this particular program, it was funded by the Department of Health with the explicit aim to reduce emergency admissions. What we found is increased emergency admissions. So this study was never really quoted by the Department of Health for reasons I'm not entirely sure. And it hasn't really been widely proposed, which is interesting, even though actually we did find evidence of cost savings. But for some reason that disappeared in the overall reporting of that work. So, as I said, what we find is often, rather more than not, patients should be the ultimate beneficiaries, but oftentimes we don't see that. So for me, when I look at this evidence and looking also some more recent work around person-centeredness, the key question arises, where's the individual as a service user, as a carer, as a community member, a taxpayer in all of this? And I found this graph quite helpful by Karman and others, published in 2013, which present a multidimensional framework for patient and family engagement in health and healthcare, looking at the micro level of direct care, the meso level of organizational care, and the policy-making level, and really trying to understand to what degree are we actually listening to people at these various tiers, and to what degree do we take account of what they have to say, if anything, if you just were to ask. So we did look at the evidence across Europe to understand a little bit better to what degree are people involved in their care at these various tiers of the system. And what we find that the evidence is actually pretty inconclusive at the moment. when we look at some of these strategies, we do find that some of them impact positively on some anticipated outcomes for some people in some settings. No, that's not very good, I have to admit. The best evidence really is around individual level approaches, such as shared decision making and self-management, but even here, the evidence isn't actually that great. For various reasons, which we might want to talk about a little bit later. And because the evidence isn't that convincing, there's continuous challenges in rolling out or routinizing some of these promising initiatives. Even shared decision making, where arguably the evidence is pretty good, countries are struggling to roll it out for various reasons, partly because the evidence isn't quite as good as we would like it to be. And what we found really is, it's all about the patient, yet the patient isn't really involved in any of that, or only marginally involved in any of that. So much of the evidence is really dominated by professional, organizational, and the policymakers' perspective, and there really is a need to really listen better to what people want. So we've developed, looking at the evidence, some ideas about how to better achieve person-centered health systems and looking at some of the levers and strategies. And one is really about strengthening capabilities, about making use of existing levers, invest in education and training, and measuring and monitoring. I'm going to run through each of these very briefly, and of course these are not exhaustive, there are other levers, but these are the ones we've identified in our work, which is hopefully going to be published early next year. So just looking at the first, strengthening and enabling capabilities of people at the different tiers of the system. Many policymakers, certainly in Europe, talk about strengthening health literacy. And what they mean is educating the individual to better use the services available. And this is fine, but actually it falls very much short of that. Everybody else also needs better health literacy. And when we look at conceptualizations of health literacy, we find that often they are being defined without the public in mind. So we don't actually know how the public thinks about the idea of health literacy, which we found quite surprising and a little bit depressing, I have to say, and that not much more work has been done around that. And what we would argue that there really is a need to incorporate professionals, providers, managers, and decision makers at the different tiers to also strengthen health literacy among those. And more recently, the idea of health literate organizations or organizational health literacy responsiveness have come up and been proposed to really embed the idea of it's not only the patient who needs to understand information and communication, it's the entire system that needs to have a better level of capabilities to actively engage in those partnerships. Digital technology are often hailed, certainly in Europe, as the big solution to all of our ills and to empower patients. And again, this is in theory laudable. In practice, what we do see is this continued digital divide. And if we don't overcome the digital divide, I think it's going to be quite challenging to really make good use of all these technologies that are available. And these, again, are just some slides or some figures from a recent study published by the European Parliament looking at internet use among EU citizens between 2005 and 2014. And even though use has increased over time, we still see a huge divide between low educational status and high educational status, as well as use by age. Why is this important? It is important because those who are least likely to use the internet, as in this case, or digital technologies, are actually the ones who are most vulnerable in terms of health risk and chronic illness. So if we are not careful, we might reinforce existing social inequalities in health. We do need to strengthen and enable the redesign of services at the different tiers of the system. And here, we really need to better understand what actually matters to people. And we are not very good at that. The metrics of success, what matters, are often defined by providers and payers. and not by the people who are affected. There's a need for novel and adapted measures that recognize the role of the person more specifically. So looking at measurement across clinical pathways and service boundaries, to really look at broader indicators of what service delivery actually means for the individual and their carers, and to also define better measures of concepts such as empowerment, autonomy, care coordination, and self-management capabilities. At the moment, these are very much buzzwords, but very little understanding of what it actually means on the ground. We need to invest in education and training, and here I mean education and training of providers, professionals, managers, health policy makers, because all of these require a new range of knowledge, skills, and competencies that we need to embed better in training programs. We need to really better understand how we can develop a workforce that actually engages with individuals, but also we need to understand better how managers can ensure, for example, the design, if you like, of health literate organizations. And oftentimes, organizations are at the crossroads between what's being demanded from the center and what's being demanded locally, and how they can overcome these often contradictory demands and perhaps also resist some of the issues that come from the center. There needs to be a wider policy framework which is really alert of these potential tensions and unintended consequences of policies. So, for example, we often have national policies which are great, but are very difficult to implement locally simply because the circumstances don't allow for doing so. And how can we create policies that take advantage of those? And often what we also see that we develop or implement policy and just expect people on the ground to implement them. But we often don't, people on the ground often don't have the competencies, the time, and perhaps the capabilities of doing so. So we need to invest on those competencies as well. And finally, we need to think about healthcare system design. As I've mentioned earlier, the evidence is most robust at the kind of interpersonal level, such as shared decision-making or self-management support, but we don't actually understand a lot about the organizational and system level, and we need to do more research on that. A recent systematic reviews has identified some levers for the implementation of person-centered care, and I've listed some of these here. Now, for those of you who've worked in change management, many of these levers actually don't look that much different from change management approaches more broadly. And it really is about committed leadership, of engagement of staff at all levels, of a systematic measuring what's going on, of systematic feedback, of a culture that allows for change, that enables change, and an adequate policy framework. But also, I think, a very clear understanding of the incentive system, and does it actually produce what we want it to produce, or does it have unintended consequences? And finally, I think what we also need to strengthen is a systematic approach to evaluation and to allow for organizational learning, so to really see this as a continuing process rather than as a one-off change. So this is the study, which will have a much nicer cover when it comes out eventually, I think, in January. What we have looked at and what we have found is that person-centeredness has become a key priority for policymakers, but it's often actually put in as an afterthought. I went to a meeting at the European Commission a couple of months ago where we talked about the future priorities of research on health services and systems. And all the usual suspects were mentioned, like health technologies, integrated care, pharmaceuticals, and then someone mentioned, and what about the patient? Ah, yes, the patient, of course, yes. We do need to think about the patient as well, which I found was quite illustrative of how we don't really have, we haven't really integrated the idea of the person at the center as yet. And overall, what we find is the public voice still remains pretty much absent in many of the strategies that we've been observing. And I think this is something which is quite fundamental if we really want to move towards more integrated, person-centered services. And this is all what I wanted to say. You can read up some of the stuff in some of these things I've been involved with. Thank you very much.
Take your seat. That's great. Need to run faster. Well, thank you very much. That was terrific. I was taking notes throughout because we're certainly, the language of integrated care is very much part of the fabric of Ontario. We have local health integration networks across the province, 14, with a mandate to integrate care. We've experimented with Health Links, which is really kind of getting voluntary organizations to work together without much structure to see what we could do around some of the most complex patients. We've tried bundling payments for particular diseases and conditions, mostly acute and post-acute, but looking at does that make a difference in terms of the connections between providers. And we've got some pretty innovative models of care, and I've struck, having come back to the Ministry of Health and the health sector after doing other things for 4 years, that there really has been some very innovative progress. And as we start to think about looking at integrated care as a major piece of work for us to work on together, we've got some pretty interesting prototypes and lots of interest. I think the ministry has actually collected about 30 different project ideas that are basically been developed locally for us to mull over and see how we can animate within communities. So the topic is remarkably timely. We are in the process of engaging leaders from multiple sectors, and I'm glad so many are represented here today. So we'll have a microcosm of the kind of work that we've been doing, including delighted to have a municipal rep, healthcare planners, providers, public health units, researchers, and of course patients, which I should really put at the front end, because our work with our Patient and Family Advisory Council chair and others is really very much embedded in our thinking and our emergent thinking about how to accelerate movement towards integrated care. So with that, I think I'll introduce the panelists, but it's as I say, this is a journey we're all on. I'm not sure if I'm delighted that it's kind of still in motion in other jurisdictions. We have a chance to catch up and hopefully set the pace. Although I wish somebody had a kind of cookbook and said, if you did it exactly this way, then you will be successful. So we're obviously going to have to kind of work this through together in communities, in the context that they find themselves in, obviously with patients. So our first panelist, very instructive in our work on Health Links. So always a pleasure to have Walter Witches. He reminded me today we were going to see each other 3 times in the next week. He's a professor at U of T's Institute for Health Policy Management Evaluation at U of T, and the research chair in Implementation Evaluation Science at the Institute for Better Health at Trillium Health Partners. I'm going to introduce the panelists, and they can come up, and then Walter, you're going to kick off. The second panelist is Carrie Kaluski, Applied Health Services researcher, assistant professor at that same august institution at the University of Toronto, and at the Bridgepoint Collaboratory for Research and Innovation. Welcome. Our third panelist, well known to me since we both spent a good chunk of time in the cancer system, is Sarah Downey, President and CEO of the Michael Garron Hospital, Toronto East Health Network, which is a large community hospital and teaching hospital affiliated with the University of Toronto in the eastern part of the city. And our fourth panelist is Graydon Smith, Mayor of the town of Bracebridge. And you've been a part of several health-related initiatives and boards, including the Muskoka and Area Health System Transformation. And I believe that you heard from Alan Nolte in a very compelling presentation earlier. So each panelist is going to have about 5 to 7 minutes to give an overview on their perspective on health integration. And then we're going to have a moderated discussion. So think of your questions as you're listening to these panelists. I've got a couple, but I really want to hear from you. So with that, Walter.
Okay, great. Thanks very much. And thank you very much, Ellen, for taking all my comments away. So it was a great start to watch those awesome slides and for citing our work. So thanks very much. I'm going to emphasize then a couple of the things that Ellen mentioned that I think are really hopefully helpful and instructive for us here in Ontario. First, though, is to say a little bit about what we're doing here in Ontario and where we might be placed. And I think we're placed in a pretty good position. Ontario is actually quite active in the area of moving towards integrated care models and approaches to care. I have a number of colleagues that we work with internationally to compare programs around the world. And particularly here in Ontario, I think among other jurisdictions in Canada, my colleagues in other jurisdictions in Canada go, I wish our government would actually try something new. So both to Helen and our prior government as well, that trying these models of health links, trying integrated funding models, trying bundled care, experimenting, and then taking things to scale is a very brave thing to do. It's much more easy to continue on in the siloed approach to care and paying individual providers to do what they've always done. So I say we've been doing quite a bit here. That doesn't mean we've achieved any great state of integration, I think, at a systematic level, but we do have pockets. Not all of these pockets are really well recognized. Sometimes we get out and we talk to a family health team and we find out what they're doing at the micro level, actually, in pulling together different programs is pretty amazing. And what they have to do is they have to pull together a lot of different specific little programs often in order to be able to integrate care, because there is often not license or mandate to do something at scale. So I'd say one of the real things we need to work on in Ontario is having opportunities to do, as you saw that slide of the Netherlands, cutting apart their country into regions of a couple 100,000 people or through the vanguards, a couple 100,000 people, and saying here, in this area, you are going to try and advance population management and not just deliver a care program to this particular subpopulation. So I think the opportunity is ripe for us. In those opportunities, I also think that it's important for us to think about what it means from the individual client and patient level. And so there I'm going to say we need to focus on, I'm not sure the right word is clinical integration, but I mean that person-centered integration that is experienced by that individual, rather than thinking about the professional integration or the structural integration across organizations into one large, managed care organization or integrated delivery system. I think getting the focus that the reason that you want those other mechanisms is to support and sustain what really has to be clinical integration at the front coalface lines. That, I think, then leads me to some of the areas where, how would we know if we're doing that well, and how might we think of some of the mechanisms that could build up or improve on to get there. So the first off, I will say monitoring the emergency department to find out whether we're doing integration very well is probably not the best way. I think that that can end up having, people who don't have integrated care can end up in the emergency department, but people end up in the emergency department for a whole lot of reasons that are not related to integrated care. It's probably not the most sensitive measure. I think we have to do a much better job of talking to people. People with multiple chronic conditions, people with health and social needs, to understand whether their care is being monitored. The best information we have is that Commonwealth slide on those 5 questions on patient experience around coordination of care, follow-up after acute care hospital. That is the data we have for Ontario. We have, and that was presented for all of Canada. We have a subsample. So because that actually talked to individual patients and asked them, did your next provider know where your care, knew where you're coming from and why you were there? So I think that that's really important, and I won't say more than that because I'm sure Carrie's going to say lots about that. But starting at that front. And then I think using that information and using what we know about programs to have a much more structured learning approach. So we go out and we try a program, we might do some measurement, we'll see whether it affects emergency department visits, and then we'll move on to something else. And I think that we need a more organized approach to iterating, and I have now saying more so, I would really like to see the second round of quality improvement. I see a lot of people do some planning. They decide on a program, they implement it, they evaluate it, and then they move on to something else. Instead of saying, what did we do well, where can we improve? and how do we iterate in order to advance. And so those will be my notes for now, and I'll be happy to answer
Fantastic.
more later.
Thank you very much. On to Carrie.
Great, thank you. And that's a great segue for what I'd like to talk about. And I'm not a patient and I'm not a caregiver, but what I feel really fortunate with is that I get to sit down and interview hundreds of patients and hundreds of caregivers and people that have multiple conditions, major social issues, and lots of challenges as they try to navigate all the different parts of the health system. So, Ellen, when you showed that slide of all the lines going in all these different directions, it really does speak to how patients experience the system. And I mean, the hospital and the primary care piece are small pieces of the entire picture. So there's a lot of social services, housing, financial supports that people need that they're trying to navigate as well. What was missing from that picture, which I think really needs to be highlighted, is we often forget to mention and talk about the caregiver. So what ends up happening is, you have a patient in the hospital, and they might be lucky enough to have a team that mobilizes around them, and they're giving them tons of instructions about, okay, so you're going to go home on Tuesday, and then the doctor's going to call you, and then home care is going to come. And then the caregiver shows up and goes, "You're going home tomorrow? Who decided this?" And suddenly the caregiver's working full time, they have children of their own, and suddenly they're trying to recalibrate their own life and trying to manage the care of the patient as well. So how do we effectively recognize caregivers, so family members, and bring them into the conversation so that they become part of the care planning? And I think there's some organizations that are doing that really well. But there's others where it remains an afterthought, and we might say things, we might talk about privacy issues. Well, the patient doesn't want their family involved, or we don't have time to get the family involved. And if we start to ask the family questions, we can't necessarily do what they need. So there's a lot of barriers that I think people experience that then prevent these conversations from happening. But when we've had a chance, Ellen, to your point about what matters to people, under Walter's leadership, we did 172 interviews with patients, caregivers in New Zealand and multiple places in Ontario and Quebec, and in multiple languages. So for the first time as a researcher, I wasn't just going to the upper middle class, white, English speaking. And we conducted 2-hour-long interviews. We had tons of data, and our team actually went through their stories line by line by line to understand and unpack what actually matters to people. So we didn't specifically say what matters to you, but it really came out in their stories about, this is my journey, this is what happened, this is what it's like for me as I live my day-to-day life. And from that, we actually came upon 6 common constructs. Of course, the examples vary by different people, but 6 common things that really mattered to patients, multiple languages, multiple jurisdictions, and their caregivers. And one of the fundamental things is that people want, and this won't be surprising because I think it's important to all of us, you need at least one person that you can count on. It doesn't matter if it's a neighbor, a volunteer, a caregiver, a provider, someone, your go-to person that's actually, if you text them or call them, they're going to respond, right? And they're going to be helpful because they're connected to the resources that you need. But the one thing we have to keep in mind is that, because patients would describe that, they say, my primary care provider is awesome because I can text them anytime. I thought, well, that's great. But then how do we prevent the provider from getting burnt out? Because all of us, when we're on and we're responsive to our peers and our networks, that's great because we're helping people. But how do we protect our own time, whether we're a provider, a caregiver, whatever it is, to ensure that we can be that go-to person or make sure that's in place without the system kind of falling apart. So I think that was one fundamental piece that was really important. And when people had that in place, they just felt a little bit more confident and relieved because they weren't sure what was going to happen tomorrow, and they weren't sure what it would be like when they fell off the cliff going from hospital to home. But they knew if they had that one person that could help coordinate or answer questions, it made the world of difference. And again, it's not rocket science, but it really was sort of the fundamental thing. People also talked about if they went to, say, a visit, any visit in the healthcare system, if they felt heard. So if they're sitting with a provider and they don't feel that they're rushed out the door, again, it's not rocket science. It's feeling like, oh, so-and-so actually cares about my kids and my family and what's going on in school and work, because it's like any relationship, when you feel that you're making that connection to that person and they're really listening to you. And so with that comfort and that trust, you then start to unpack the bigger story beyond the hip fracture that just happened. Then you're learning about, oh, so this is why you're worried about going back home, is because your family member lives in a rural area and you also want to make it to your, son's graduation and blah, 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 blah. Oh, because we had that trusting, ongoing conversation in that relationship. And if you look at the context that supports that, you're looking at getting away from a fee-for-service model, having a team-based approach and that sort of thing. So all of these kind of attributes have a bunch of characteristics that support them. Other things that are pretty obvious, being independent. So as a caregiver or patient, doing things that are meaningful. If you like sports, if you want to get together with your friends, like even though you have multi-morbidities, how do we ensure that you can continue to do those activities in a way that's meaningful for you? Knowing what to expect. So a lot of people, as they have multiple conditions, they don't really know what's going to happen down the road, and they won't know what the medication impact is going to be on them. They don't know that it's normal for 2 weeks to go by and to feel no different with your depression, that it's going to kick in later. To have someone explain that to you and understand what that means is critically important. And and feeling safe. So for example, we build all these beautiful models, say hub models and primary care models, but Mr. Jones doesn't have the means of transportation to get there. He's scared to go on the streetcar. He's scared to walk on the sidewalk where it's not a safe neighborhood. So things about feeling safe and having access, the final thing, having access to meaningful health and social care is really important, because again, you can put all these great services in place with all the bells and whistles, but if people can't actually get there, and if it's not meaningful for them, then it really doesn't work. And a final point is that a client said, the reason why I like going to my primary care office is because I can get food when I go there. And my friends are there, and he was a new immigrant, and he was building a community. And I thought, what a beautiful way to naturally build supports for people in a way where they don't feel that care is being done to them. It's just naturally kind of embedded within their environments. And I thought there's so much to learn through these stories with patients and families. And the next part of this is, how do we then respond to this? By creating the models of care that they talk about with providers, with decision makers, so we can do this together and ensure that everyone's happier with the result.
Great, thank you. I'll look forward to having discussion about how we actually develop those models of care, because I think that's the translation that we all want to make. But Sarah, why don't you take it from here?
Sure. So thanks for the opportunity to be here. I'm speaking from the perspective of a community hospital that serves a population of about 300,000 people, and who really wishes to improve the health of the people who surround us. And our vision is to create health and build community, and that's because we understand you can't just treat the illness and think that the person is fully better. So I guess one of the questions you might ask yourself is, what do hospitals bring to this discussion? So much of the discussion is getting people out of hospitals, but what is the viewpoint of hospitals, and what expertise and help can they bring, and why is it important to us? And first of all, it's pretty clear that we have knowledge of the illnesses and the social problems that affect populations. We do a lot of cataracts, but we do a lot of cataract surgery on people with diabetes, or we know what COPD rates are and the smoking rates in communities. And we see firsthand the impact of comorbid conditions and aging of populations on the people we serve, and we appreciate how much harder it is to treat people and develop care plans for people who have more complex illness. The other thing I think we appreciate as a hospital is the impact of social determinants of health and the ability for people to get truly better. And if you can't get the prescription filled because you don't have insurance, and if you don't have stable housing to go to, or if there's a lot of pressure on you to get back to work because you're the only income earner feeding a family, we see what those things are, and you're more likely to come back to a system if you're unable to be socially healthy. The other thing hospitals bring is we have a lens on it in places where the system fails people. And so if you can't go to your family doctor on Saturday night, if you've sent your spouse home for palliation and the home care team hasn't shown up to help with the pain management and the issues, and so we're the place that's open 24/7. And so we understand firsthand where the system fails or can't come together to help people consistently, and they come back to hospital. And so we see, for instance, when we look at who comes to our emergency department, we understand that there are neighborhoods and apartment buildings that have hundreds, thousands of visits to our emergency department every year. So we see the hotspots, we see the systems where they don't really work. And the other thing I think hospitals bring to the discussion, and I'm sure the Mayor of Bracebridge will confirm this, is hospitals have reputations. They're often trusted in systems. People come to emergency departments because they trust the people who work there. And we employ lots of people, and I think by and large we have good reputations in the communities we serve. So what do we need to do as hospitals to help to integrate care? My pieces of advice are this. One is you have to appreciate the lens from which you see the problem, and it's not the entire lens. And so I often say in speaking with partners with whom I work in trying to integrate a system is I only see an angle. I see the people who are sick, I see the people who need me. I don't, to reflect on Ellen's discussion, I'm not the public, I represent the patient, and sometimes the patient, the caregiver. But we come at it from a lens, and I think you have to appreciate your lens is not the only one that needs to come together to solve the issues. You have to know your strengths, and you have to understand your limitations. And so as a hospital, our strengths are in employing lots of healthcare providers and making good diagnoses of care and offering good treatment of people. But we have limitations. We're not good housing providers. We don't know how to do that kind of thing. We're not the home care provider. Sometimes we're a limitation because of the size of the organization we represent. The people we work with feel intimidated by it. So understand your limitations. The other thing I think is incredibly important in building integrated health systems is the need to be trusted and to be humble. And I'm not sure all hospitals in Ontario or around the world are particularly good at that. But if people feel you're there to take them over, if they think you're there because you have all the answers, that's simply not true. And you can't build the kinds of partnerships you need to change the system without people who trust you and who are willing to experiment with you. And I think that takes a lot of time in order to build it. Ellen talked about this too, you got to watch out for incentives. We can't change them all, and some of us really are incented differently to solve problems. And you got to be mindful of it, and you got to work with it. Some people are fee for service, some of us are global budgets, some of us have elements of funding you're trying to bring together. But we have conflicting incentives, and you have to be honest about it and try to find solutions around that. And so just briefly, and the other thing I'd say is, you kind of got to take it a year at a time. I don't think to figure out how I'm going to change smoking rates in the communities I serve, it seems totally impossible. But I can sure look at transitioning people with COPD using the PAUSE, the patient-oriented discharge summary framework, a lot better to smooth transitions of people who have COPD. And do a much better job, for instance, of assessing whether or not people in hospital are willing to engage in smoking cessation and get that path started. So the big goals are daunting and hard to get to, and I really think organizations like mine on an annual basis have to come up with good practical strategies that begin to set this ship a sail towards the ultimate destination.
Great. Thank you very much. Good advice. Thoughtful. We'll get back to some of the themes there. Graydon, Mayor of Bracebridge.
Thank you. Obviously, we're coming at this from a municipal perspective, from a very different place than the healthcare system comes at it from. And it's really one of representing the public and ensuring that we have communities that are sustainable. And part of that sustainability is through having healthy citizens and health services available to citizens. I think I'm here tonight because Dr. Brown and I had a conversation at one point a couple of years ago, and I happened to mention that municipalities really are more and more in the healthcare business. And we are. There are those things that are obvious in terms of municipal services that are delivered, whether that's the paramedic service that you'll find in every community, or whether it's our contribution to public health, which is about 25% of the bill, but often higher, whether it is the fact that upper tiers and single-tier municipalities are obligated to run long-term care facilities. But it has gone beyond that in recent history, and I think more and more so, to the point where more municipalities are kind of that point of entry for the public to talk about what they want. And we need to express that to those in the healthcare community, what it is the public is saying to us. The conversation in our community, and what really focused it for me, was around a hospital. We had one hospital with 2 sites. and there was a discussion about what the future of that hospital would look like, and it was decided by the board at the time in 2014 that it should be one hospital with one site. And that would have massive ramifications to the communities of Muskoka where the two sites were located. And the biggest part of the problem was, while we were expected to pay for upwards of 20% of the total cost of that project, which would have been in over $100 million, there was no formal process to bring us into the conversation at all. We were somewhat consulted. We made points. We hoped the points were listened to. In some cases they were, often they weren't. And a decision was made that the community reacted incredibly negatively to, and it didn't have to be that way. That resulted in conversations with the LHIN, conversations with the hospital, conversations with a variety of stakeholders. The LHIN did their best to put the two sides together. It didn't work very well, but we started to make some headway when we did all agree about some principles that were based around patients. And we started a pilot with Dr. Brown's help and with others in our community called MAST, which was the Muskoka Area Health System Transformation. And it was really based around a number of the principles that you've heard about today through the various speakers, and was a new way of looking at things. And I think everyone was at the table with certainly the main goal of patient care in mind, but with other secondary or tertiary goals that they wanted to achieve for the service they were providing. So everyone came at it from a really positive perspective. And it was important that municipalities were there again to talk about what our communities expect, what our communities need to go forward. I specifically obviously represent the point of view of smaller communities. Our community is about 16,000. It probably doubles or triples in the summertime, so we have some very unique challenges, especially around emergency care in the summertime, and making sure that everybody has adequate health coverage and care when they're in our area. But it was a great dialogue for a year. It was based around, again, principles of patient care that simply made a lot of sense to a lot of people. We focused it around the story of one individual. His name was Gary. He'd had a very traumatic incident occur in his life that took him from someone who would be considered healthy by any metric and was in a wheelchair for the rest of his life and on a ventilator and basically unable to function in ways that he had previously enjoyed. And he had challenges with the healthcare system that were simply astounding to hear about, and you wouldn't think would happen in a healthcare system in a first world country, and it was disappointing. And we took Gary's story as the rallying point and the challenge to try and invent an integrated model for Muskoka that not only would provide a better outcome for him and any other patient that entered the system, but also would save money and have a streamlined governance model. And getting back to the money part, it was important that that money was reinvested locally back into sustaining the healthcare services we had and possibly growing the healthcare services we had in our community. Because if you are in a small town, you are trying to hang on to what you have. It's not always about what can we do better, it's about what can we keep on doing with your fingernails a little bit in the wood, holding on as best you can. Unfortunately, MAST didn't get past the theoretical stage. When we took it back to the LHIN, I think there were a variety of reasons why it somewhat stopped there. But we do see an opportunity to continue forward with it. District government in Muskoka at our last meeting last month reaffirmed the principles of MAST, reaffirmed their support for MAST, and we believe that we can be valuable partners in a conversation expressing the community's needs, their desires, and the municipal need to be part of a conversation. And I don't want to reduce it to just money, but if we're paying, we need to be at the table, and we deserve to be at the table. And when someone comes to you and says, we need $120 million to build a hospital, we need to be at the table. But we can do it better than we're doing it now. Municipalities are a mature level of government that have a lot to say about the individual circumstances in each community throughout Ontario, and we're looking forward to the conversations in the future that will ultimately lead to better health care for our citizens.
Terrific. Sorry, I'm just writing notes on what you're saying. Thank you very much. Those are terrific comments. I think, what I got out of this is sort of, obviously there's the implement, and I'm all sort of interested in how we get from here to there. We need to iterate, we need to listen to caregivers and patients. I loved, Sarah, sort of know thyself, and understand what perspective you bring. I think, again, it was also sort of start to approach it sort of incrementally and chunk it out into ways that make some sense. And trust in relationships and obviously engagement with partners is critical. But I will give the floor to our keynote speaker for some comments. They're probably going to be far more profound than mine, so please.
So yeah, I was thinking of what to say because I think it's actually, I agree, which is probably too short a comment on the comments. But I wanted to pick out one particular point, which Sarah was mentioning about the role of hospitals. What we see in Europe is this move towards moving care into the community on the belief that care in the community is going to be cheaper. And this underlying drive, we don't really need hospitals, we need to get rid of them. And I think there's a false, calculation here, because we of course do need hospitals. What was interesting, and I mentioned that earlier to Carrie, I was involved in a project in Belgium where they tried to define integrated care. And integrated care was set aside from primary care and acute care as a third sector. And I think this is not what we want. The idea of integration is to actually bring primary and secondary care together and not create yet another layer of services. And this whole debate about moving care into the community is appropriate where it is doable, but of course it requires capacity to be strengthened in primary care as well in the community, and often this capacity actually isn't there. And my worry is slightly that we kind of move into a wrong direction and that we see integration as the end rather than as a means to improve population health. So in some localities, a local hospital might be the right organization to sustain, to provide integration. In others, it might not be. And I think we need to be much more, as you were highlighting, you need to look at the local context within which people live and what is the most appropriate service. And it might be that the merged hospital might be the right, the right institution. It might not be, but I think we need to be much more flexible. And I think, Walter, you mentioned earlier as well, that we need to look at the local context in particular to understand what is best for the population.
That's great. So I get to ask a couple of questions. Stany's team very capably gave me some, but I'm going to be selfish and ask one that I really want to know, which is, I sit on top of a $6.1 billion, that's the size of the ministry. That's the oversight that we have directly at the Ministry of Health and Long-Term Care. And we have a lot of funding and policy levers at our avail. And every time I talk about, integrated care or, health things, I've always kind of painted the ministry and how we've locked value into the silos and the rigidity of the rules as sort of part of the problem. And I guess I would, and so somehow we need to be more enabling and more flexible, more sensitive to context, able to kind of go on a journey around models of care. But I'm really interested in your perspectives on what are the things that the policy makers and funders can do. And Ellen, you talked about that in your talk. But what are the things that we could really do that would make a difference, that would help first get this sort of, not that we're not nowhere, but first get this kind of moving and then in scale up, because I certainly work for a government that's in a hurry, but also I think it's important that we do this for patients as well. So anybody who wants to take that? You want me to start? Yeah, go ahead.
Well, if you're looking for somewhere to send money, Helen, I have some proposals. But all joking aside, I have winters. I'll give you an example. So, and it relates to funding. I have, for instance, in my organization, via the LIN, some surge funding to spend this year to ramp up services over the winter months. You have summer surge, I guess, in Muskoka. We have winter surge in Toronto. And because it wasn't, owned by any, it comes to me, I have an accountability agreement, I saw a great opportunity to be able to figure out investments outside the hospital to see if we could, in fact, prevent people. And it's not to, I feel badly saying that. We're a hospital, we treat people is what we do well, and we're happy to treat people when they need us. But could we actually keep people healthier and in their homes and in their jobs and taking care of their parents or their kids or whatever they do through different kinds of investments? And it's been really easy to come together with trusted community partners to think up strategies. And so, we're out vaccinating people in hotspot neighborhoods a lot more than we might have otherwise. We're trying to build models of urgent care capacity outside of hospitals so that people don't have to come and wait in an emergency department on Christmas Day. Or we're figuring out how to do a day 2 discharge of COPD patients home with a link between the specialist and the hospital and enhanced home care supports. And it's actually been incredibly easy to figure out incentives or programs to keep people well. And I think, why does that work? It's because I actually didn't have to take the entire risk myself on this. There was a pot of money that we could allocate differently and try things that would help inform the future. And so again, figuring out exactly how to deal with things like winter surge or daunting tasks. But when you start on a few things, you realize that the change is not as hard as you might think it is. And so if you could, incent people to come together and work and tie the reward to a communal goal, a shared outcome, then I think we'll get some of the traction in the system that will get us further faster.
Excellent. Anybody else want to give us some advice?
Sure. I'd be interested to hear Ellen, because she's always looking around the world. I'll say, when it comes to policy, I always find actually looking outside is quite a useful place, so we can actually see comparatively what are different people doing. And we've done a little bit of that, particularly in the area of integrated care. And I'd say a couple of things that we've seen as common for successful innovation. I mean, I'm going to say integration is it's a lifelong journey. It's more than a lifelong journey, right? It's not something you arrive at. It's something you head towards. And I think setting that vision is one important role for policy. And that it's not something integration is not a program we implement. It's a vision that we work towards. Then I think the support for programs and pilots with built-in mechanisms, and I say this is something that the Ontario Ministry is doing a better job of with evaluation and review. So Vanguard's did that, I think, as well in the UK, and the Netherlands in their population models have done that. So set those pilots out there with clear ability for evaluation and review and reorientation after a certain period of time, that this is not the single model that's going to last. It will iterate, it will evolve. And on the process side, I think organizations can do a better job of monitoring, iterating, and evolving. And then when we find the things that work or the barriers, so there are restrictions in what providers are legislatively allowed to do, and they need to expand their scope to use more lower wage or lower cost resources to accomplish similar tasks, probably more easily, to not restrict that from happening, but to enable that, I think, to happen. Those are the more kind of regulatory side of things, I think, that we see. And then, so that's kind of changes in responsibility. And then when there are needed changes in how we pay for things, too. I think sometimes that those rigidities and that they start to evolve from when we see people trying to do things and experiment. And one of the things I like about the United States and their public health system through Medicare is the express license to innovate through something called waivers. And they do have a built-in legislative capability of stepping outside of payment rules, regulatory rules, in order to experiment. And anything that you usually see that somebody raises up as being innovative, Medicare social savings plans, OneCare in Massachusetts, they're all waiver programs because they get to break the rules in order to implement them. And I think if I were to be in your role, I'd be trying to figure out how do you set up a structure that allows rule breaking.
Yeah, fantastic. Anybody else want to weigh in?
So mine, I put my social work training hat on, and I always think about when things are working well, when patients and caregivers share a good story, if a provider is satisfied, what's happening is because they've had the time to build relationships. And sometimes it's hard to measure and it takes time, but building the relationships, the trust, But having the time that we all lack, but having the time to slow down and actually think about what we're doing, what's working, what's not working. We're always in a rush. You know, I think about, you know, that game Whack-A-Mole, like we're just reacting and we're trying to stay on top of everything and stay on top of our emails and, you know, do everything quickly and, you know, transfer people to the next setting as fast as possible, but not having the time to slow down. So what incentive, what structure do we need for us all to take a deep breath and start having conversations with people in our organizations, but also across? And what would that look like? And one practical fundamental question, which was suggested by a caregiver advocate and retired nurse, was asking everyone, provider, caregiver, patient, ask them what they're most afraid of. If you want to quickly get to, you know, part of the conversation where you're getting to solutions, what are you most afraid of? And then you build around that. So you quickly get to what's most important to that person. And it could mean an uncomfortable conversation where you might not have the answer, but the fact that you're listening, and if you have the time to build those partnerships to then move things along, I think it could go a long way. So if we're going to build a measurement tool, I'd say that's one of the most important questions.
Excellent, thank you. Ellen, did you want to get in there? Sir? Go ahead, anybody?
Well, okay, I'll jump.
Please.
You know, I'll reiterate the local context piece again and say that, you know, I would challenge the ministry that whenever they're having a conversation about what their next, you know, broad policy initiative is, that it does take into consideration local context as much as possible and local condition as much as possible. And I've said the same thing to, you know, the Minister of Housing and the Minister of Social Services. And when you start having conversations about social determinants of health, those ministries are relevant to the conversation that's going on in your ministry. But, you know, whatever circumstances happening outside this area tonight is different than the circumstance that's happening in Bracebridge tonight or tomorrow or in the future. And so that local knowledge is critical, and that flexibility for the local point of view and the local needs to be captured within policy is simply a must. You know, I would love to see us be able to go forward with some of the principles of MAST, if not all of them, and implement that on a local level and see how it works. And so I think there's value in pilots in different areas to see how that local circumstance plays out and what you can take from that and apply in other situations, and you know, what worked and what didn't locally as well. But, you know, from a small urban perspective, again, we've seen that broad, inflexible policy, specifically around hospital funding, hasn't worked well for us. And we've been asking for change for that with 3 ministers now. And, you know, we see that, or are told that, you know, some change or assistance may come. But I think if it had been looked at a little bit differently in the first place, that one size often not only does not fit all, but can't fit all, that some of those changes on the front end will make for a better back end outcome.
Well put, thank you.
So I guess from a policy perspective, I think one of the things we've seen is certainly consistency of policies is key at the different tiers. So what we've seen, for example, in England, when we look at self-management support, so it's high on the political agenda. GPs are supposed to support their patients, yet the payment is very much still based on biomedical indicators rather than on supporting the patient. So GPs naturally will look at the payment rather than what they. So I think we need to really think about, you know, to what degree does this policy, is it actually doable and enforceable locally? The second one is also what I often see is there's a lot of buzzwording going on. So integration, that's the solution. Person-centered, that's the solution. Access, that's the solution. We often apply solutions to problems which we haven't quite described very well. So I think what we still need to sometimes go back to is the drawing board. What is the underlying problem we want to solve? And to what degree does this particular model of care or what we are introducing actually solve that particular problem? So the kind of theoretical basis, the theory of change, if you like, which is really quite important, and we often don't see good evaluation results simply because we haven't looked at that this particular innovation is going to solve that problem. The other one is for me also this perpetual problem about bottom up and top down and what's the right balance. And you have already mentioned the issue of local context. And I think there has to be some regulatory framework. There has to be regulatory security and safety for those actors. But at the same time, people have to be allowed to do things and to make mistakes. I'm not going to say breaking rules, but I think there has to be some allowance for going a wrong path and then adjusting and measuring, adjusting, and then going forward. And the final one, I think this is something which is really close to my heart, is really if we want policy to be implemented, to help those who are supposed to implement it actually to do so. So to not just say, this is what we're going to do, get on with it, but really understand, okay, this is the training we need to invest in, this is the kind of time we need to give people to actually, because in the innovation literature, what is being reiterated in the theory, but never really been done in practice, is that organizations need to learn to function differently, and that needs time. And I know policy is under a lot of pressure, but this time needs to be given to people to change and to work differently. And I think this is something which is going to be key, whether it's integrated care, whether it's anything else really, but it's a time element which is often lacking.
Yeah, very practical and helpful. When I think about, we've talked about pilots, and we've talked about iterating, we've talked about kind of finding local context, we've talked about a little bit about the sort of the policy levers. I guess, are there other levers? And, one question, because, we've got certain capabilities, at the province, right? We have legislation, we have policy. We put into place structures, and so when I start to think about scaling up, I immediately, because a bit Cartesian, I worked at Treasury Board, I like to think a little bit about structure, and it was the one thing that we didn't have at our avail when we started the work on health links 4 years ago. We just kind of allowed natural communities to come together and see what they could do. And so one question I have, and it's an honest one, is what kinds of capabilities would you bake into the structure of the healthcare system, whether it's the training capability you've just talked about, leadership development, because one of the things that I worry about as we embark on this is actually having, and I know you didn't ask me to speak, you asked me to moderate, but is capability in change management and change leadership, and how do we make sure that these things and these capabilities are brought with regularity to the challenges that we have. So I don't know if anybody has any comments on those things.
I'll start on that one, because I'm eager to say that I was saying a little bit earlier to Ellen about some programs when we looked around, the importance of bottom up and top down. And I think I'll refer to what you're talking about as the structural financing, the top-down approach. And I think that the top-down approach is most useful to support, enable, scale, and spread those initiatives that are very promising that are developed at the bottom up. I don't think really great innovation happens at the top.
I would agree. It's okay.
And so I think that recognizing those and then figuring out listening to figure out what the important components are, are they new roles? I could go by examples, right? Like we were looking at examples in New Zealand. I'll give 2 or 3 of these and I'll stop, promise. In New Zealand, giving small budgets so that people could spend money, providers could spend money, literally on making co-payments for patients' medicines. In the U.S. now, and they're starting to get waivers to be able to do this because a hospital can't spend money on paying for a patient and account for it back. That's what I mean by breaking the rules to, and then how do you make the policy shift to be able to do that? That's where I think the top-down changes come after the innovations have identified something that works, and then enabling that governance and boards. You really need interorganizational governance after people have figured out the relationships and trusting partnerships. How do you restructure so that other people will replicate that? They still need to build trusting relationships, but once you've seen something. So I think that's recognizing the components of those models that are ahead of the curve and then building the structures to make that easier for the next people. That's, I think, really, really important. Otherwise, data, information management technology, that's probably, you don't want everybody to do that on their own.
Yeah. Okay. Hope we're getting the camera. This is being recorded, right? Excellent. Okay. Anybody else want to grab onto that one?
Yeah, I think that it is a challenge. And I think the really innovative models will happen whatever the regulatory system is. Because if you have some really motivated people together, they will do it, never mind the circumstances. The challenge is then, how do you transfer that experience elsewhere? Now every country has their flagship program, like it used to be Torbay in England, Canterbury in New Zealand, or Kinzigtal in Germany. And there was a reason why they never spread. A New Zealand colleague once said to me, it's because they're really nice areas, everybody wants to live there. And so all the doctors went there as well. And this is really hard to transfer. But what is easier to transfer is, okay, what are the key ingredients that we can potentially transfer? And one of the things that has happened, certainly in places like Kinzigtal, which is, in the Black Forest, is really quite nice over there. Actually, I've never been there, but it's supposed to be quite nice. But what happened there is that they did work with the entire local community, the providers. They did work together for years, and they had a network in place that enabled them to experiment, to have trust. And trust in relationships is really one of the core things. And this is not something you can learn. It's something which has to grow over time. And it's also difficult to regulate for trust in relationships because it just has to evolve. But these are the kinds of key ingredients, and also involving those who are supposed to deliver services in the planning and design of those services. And if one doesn't involve those who are supposed to do that, I think one loses a real big chunk of opportunity. And I think what is also important is in those models, what we have seen, the ones who have really been quite successful, they continue to measure and feed back. So everybody who is involved in that network sees, okay, this is what we've achieved. And it can be very, very motivating to see we have made this program, we have saved that amount of money, we have reduced that number of admissions, etc. So there are a number of things that work very well. But of course, to scale these up, what we do need is evidence of effect. And that's where the challenge and the investment comes in. How do we ensure systematic evaluation?
Very good. So I've had a really good crack at these guys. So I'm going to open it up for questions from the audience. I hope you have some. I see a hand up there. There's actually microphones in the on the stairs, and I would encourage you just to, since we're all kind of family here, why don't you introduce yourself if you're comfortable doing that?
Yeah. Can you hear me? Okay.
Yep, perfect.
My name is Sandra Dalziel. I'm co-chair of the Toronto Central LHIN's Local Health Integration Network. I was very committed to involving the citizen's voice and the patient voice. I'm a cancer patient, and I'm also the widow of Kevin Leonard, who was on the faculty of the Institute of Health Policy Management and Evaluation. Kevin passed away 5 years ago. He lived with Crohn's disease and in later years comorbidities, and we were married for 31 years. So he and I lived the diagram that Ellen put up. He had multiple providers, chronic, complex care, and we were the integrators of his care. And certainly patients and families should play that role, but the piece of, as Walter mentioned about the silos, with the different comorbidities resulting from the treatment of his Crohn's, in comparison for me in cancer care, where there's much more integrated care, where there's the ability to access the system 24/7. So I would certainly say that there's things that are working well there. The piece is the silo care and bringing someone who is a gastroenterologist, a cardiologist, a hematologist that don't tend to work together. So that's a question in the sense that I know we're all trying to answer, is how do we make that happen when people come from multiple specialties? I want to say I'm very heartened by Carrie's presentation about the patient story, but patient stories and caregivers, a lot resonated, and I'm thrilled that we're really getting to the nitty-gritty. And I just asked, this is for organizers of the panel, where is your client-patient voice as one of the participants? Thank you.
It's a very good question. I think probably would have been enhanced by having a patient voice for sure. I think, some of us carry that with us as either caregivers or family members or, patients ourselves, but probably our provider hat or our policy hat doesn't make that as authentic maybe to others as one might think. So I will commend that to Steny and the group, and I think we'll try and make sure we do better on that. And we're all learning. I would say, when I go back to the ministry, it's also something we're learning how to integrate the patient and family advisors that we have into the policy process, and it gets a little uncomfortable at times. So anybody else have a comment?
Yeah, so I mean, first off, thank you for bringing that voice now. And I think, every time I have a question, I hope that Carrie's in the office 2 doors down from me, because she does have like a treasure trove of knowledge that we do have. I do think that it's been mentioned, it's really important to be measuring things from the patient's perspective. And what's important. I think if we do keep that measurement up front, in fact, ahead of the emergency department visits, which, don't worry, I'll put emergency department visits on the screen tomorrow and evaluations. But I think we do need to keep that at the front. I think that, because that's the one thing we do know that patients have amongst their many different providers. I still think we need to do more to think about how people experience many different providers, and even physicians. Have a real struggle when people have 4 conditions to be able to navigate that. It's not an easy task. And I think supporting people and starting with their own voice, we can start to get behind those goals and think about how do we design the rest of the components and co-design it with people and their perspectives.
Yeah, and thanks for bringing that forward. I agree with you. And sometimes I'm brought on committees as kind of the token researcher that talks to patients and caregivers, but I'm not a patient or a caregiver, so I don't really fully understand in the same way, say, that you would in caring for your husband. So I appreciate you bringing that up. And the step that I'm taking in my own research is I also realize that by collecting stories is not enough, because people were actually starting to get fed up. They said, okay, so I've told you about my experience. I told you what works. I told you what doesn't work. What are you going to do about it? Because people keep surveying me about how is your conversation with so-and-so and how is your transition. And so I think to Walter's point around the co-design, so we're tackling, you'll like this, Helen, hallway medicine. So I have an advisory group, this is my personal plug, patients and caregivers who have had a delayed hospital discharge. But the first thing they said was, it's not just about the hospital. There's so much that happened before the hospitalization. There's so much that happened after that. And to your point about the multiple providers is, as much as we try to integrate, there's always pieces that are missing. So how do we bring all those voices and the team together so you're at least getting a common message and have access to everyone together? So the people I'm working with are challenging me and how I think about how we need to design care, because the interviews only tell us so much, but when they're with you, designing things together, it's really opened my eyes to that. So I think thanks for providing the seg for that.
We have a question over here.
Thank you. Brian Schwartz from Public Health Ontario. I have worked in virtually every area of the healthcare, the health system in Ontario, from municipal EMS services to primary care to acute care emergency departments to even rehab. Now I work in public health. And public health is very high level. A lot of the comments that you've made really resonate with me as a practitioner, but also as a caregiver of an elderly parent. But what can we do in public health? We mitigate the effects of infectious diseases, environmental threats. We do health promotion and disease prevention programs. How can what we do be translated from our high-level population health initiatives to what we're talking about tonight as patient-centered care and integrated care, to reduce the burden on healthcare and also contribute to integrating care?
Who wants to take that, Ellen?
I'm not sure I can answer the question, but I can give an example where I think public health is crucial in the service delivery process. So again, if you think about self-management support, when we think about people, say, with diabetes, it's not enough to provide people with diabetes with the right tools and how to manage their diabetes. We have to also ensure that the environment within which they live actually enables them to live a healthy life. And one is, of course, the type of foodstuffs they can buy and whether they can afford to buy it, the type of physical environment they live. There was a really interesting, quite touching study by Trish Greenhalgh and colleagues where they did talk to people with complex diabetes living in very deprived areas. And they said, it's all very well giving me the advice. I just can't apply that advice in my local community because I simply can't get out of the house because it's too dangerous. Now, I don't think that public health can certainly reduce those violent, violence level, but I think there has to be a public health approach to how we provide an environment that allows people to follow medical advice, but also at the same time to live a healthy life. It's really interesting when you look at some countries, such as Bulgaria, where they're really cash-strapped, and many of these self-management support activities are being provided by pharmaceutical companies, and they really only reduce that to providing medication, and that's not the right support. It's an important piece of support, but we need to do much more about raising awareness about diabetes, that it's not only about sugar. It's raising awareness about, how can we engage. There's a lot of misunderstanding of many of these chronic conditions as well, which often disables patients who are affected to actually talk about their condition. So I think there's a lot more we can do to provide an enabling environment, if that kind of partly answers what you were saying.
Anybody else?
Maybe just, I don't have the answer to that very complex question, but I've been sitting at a sub-LIN region table in East Toronto, facilitated by Stanley with, the Toronto Central LIN orchestrated. We have had Eileen Davila there. And I'd say, the public health lens on the issues we face is actually very important. And in many conversations in my 25-year healthcare career, actually hasn't been at the table, and because we probably didn't invite somebody to attend. And I would say there is an important lens on the issues we face that comes from public health, and I think it's been valuable to have her at the table. Very thankful to have her there. And I think there's a lot more we could do to explicitly get the opinions, the voice, and the solutions from public health on the tables that I sit at.
Terrific, thank you. We have another question over here.
I have a question and somewhat of a comment. I'm a retired health administrator, and I was part of the steering committee for Midwest Toronto Health Links.
Mm-hmm.
You talk about a lot of projects and a lot of things and initiatives that happen from grassroots and going up. One of the biggest concerns being involved in healthcare for 40 years is that there really is at a top level no consensus across the board to look at integration of services. You look at ministries and they're siloed. You've got $6.1 billion. The Ministry of Community and Social Services has what? They're all funded in different ways, and yet there's no across the whole system to sort of say, we will give incentives to the integration of services as long as the services from all these ministries start working together in some ways to look at the needs of one particular client mm-hmm. or a population base. And I think that that's a big concern because we've talked about various projects here across the world. And we've done it here locally as well. And things have worked when you get small pockets of people who are willing to work together in initiatives. But there's really, when you look at the bigger picture up above, there's no incentive coming down and saying to you, if you do these things, this is what we're looking across the board as a funder, and this is what we need to do when we're looking across trying to improve health. And if you're talking about social determinants, then you're talking across all the ministries. And so I really think you can look at those small things and evaluate, and you need that, but you also need an incentive from up above that sort of says, we will support you in these initiatives.
I'll take that one. Well, I couldn't agree with you more. I mean, You know, the Westminster model kind of chunks work out into ministries and accountabilities that do create silos, and within those there's even more because we have assistant deputy ministers and portfolios and votes and items and all that kind of thing. You know, Health Links was an attempt to try and, you know, whether it's get a waiver or something on a systematic basis to try and do that. And as an urban planner, because I'm not a healthcare professional, you know, my fantasy with Health Links was that sort of bit by bit, we would start to actually substitute things like housing and other services for healthcare, because those were the things that were going to actually help people, and that they were going to be better off, and we were actually going to be spending less. And that there was a really nice sweet spot in that. And you kind of bump into the structures of government pretty quickly. I haven't given up. I'll just tell you that I still believe that there's, you know, there are opportunities to, you know, look at integrated human services and find ways to actually provide better packages of publicly funded services for people that include things beyond healthcare. I don't know how we're going to do that, but I think that's something that, you know, we really probably need to find ways to make that work. And if there's a business case that, you know, a bit of money for transportation. We had some great Health Links examples where people applied money a little bit more flexibly, actually achieved better results. Scaling that up is a real challenge, you know, and it's a challenge for government to do that. But we'll keep at it. Anybody else want to refute that? Another question, Peter. This is the head of Public Health Ontario, Peter Donnelly. So I can
Thank
be
you,
an
Helen.
MC.
I don't need to introduce myself. Thank you. Actually, I just wanted to continue the interesting conversation you'd started by drawing on some experience I had when I worked with Nicola Sturgeon, who's now the First Minister, Prime Minister of Scotland, but at the time was the Health Minister in Scotland and the Deputy First Minister. So there's an interesting parallel there. And what they did was they set out to do rather what you're describing, Helen, which is to say, how can we get the various arms of government to come together to address what in Scotland was a really pretty long-standing problem with poor health and severe health inequalities. And interestingly, what they did, and this has been written up and published in the Millbank Quarterly by Dan Fox and others, what they did was they empowered the health minister, partly because she was the deputy premier, to actually convene a committee across government of her fellow ministers. And what they would do is they would get people like myself to come and present a particular health issue. And then the health minister would turn to each minister in one after the other and say, how could your ministry help with this? I remember a particular one that a case I presented with a senior police colleague about a violent incident where a young man had committed a homicide, and there was all of the follow-on difficulty of caring for the child from a relationship that he was in, etc., etc. And she just went round the table and asked each minister to think carefully about how their ministry could contribute. And it was a very novel, I think, very constructive process. And it was surprising. There were some quite innovative things came from it. So it's really just responding to the challenge that you laid out for everyone as to how you can break down those silos and get people to cooperate across government.
We actually, there may be, you know, the natural connections may be more with the justice sector. Just to pick up on your point, we did have some Health Links that merged with their community safety tables and found that they were actually dealing with the same group of people, and there was a sort of like a Venn diagram, and they were an overlapping group. They were just seeing them through different lenses. But why don't I let somebody else talk? That would be really good.
Okay, hi. Thank you very much. This has been such a fascinating conversation. My name is Nicole Nitty. I'm a family doctor at Access Alliance Multicultural Community Health Center. That's a community health center that focuses on immigrants and refugees. And I'm also the primary care lead for the East Sub-region with Sarah. My question is around health equity, which really ties in very nicely to this current conversation, and understanding that people who are disadvantaged tend to have more barriers to accessing care. They tend to end up with poorer metrics in terms of chronic disease and mental health, and poor self-reported health, and the way they utilize healthcare as well. So my question to the panel is, what are some key changes in the approach and policies that we have that can help reduce the inequities that are being driven by the social determinants of health?
Who's going to bite? Come on.
Can I? Okay. I was really struck, getting back to the research on community-based primary health care that I've been doing with Walter and colleagues, is looking at some of the community health hubs that exist, and it's an example of municipalities, coming together with various, probably like 5 or 6 different ministries, and there's probably about 14 or 15 different funders. So I don't know how efficient that is, but it provides people an opportunity to start to use their resources a bit differently. And so in one particular health hub that we worked in, there was a lot of people who didn't have an OHIP card. They were new immigrants, but they were able to access services the same way that we can access services, but also build a community around them. And it was almost like I looked at the way they described how they used care. It was kind of like this non-invasive, thou shalt, I will do this care to you kind of model. It was very much a natural community experience where they just happened to build friendships, have access to food, build a community garden together, and then there happened to be a primary care clinic in the building, but lots of culturally appropriate volunteer services coming in to provide programming. So they're building communities, they're meeting new people, and they happen to have the healthcare is kind of the add-on instead of being the focus. And I think it's a way for people to kind of just naturally have and identify the resources around them without feeling like they have to fall off a cliff before they access. So there is something really neat about that model, and I just wondered, I don't know what Ontario's plan is to maybe further spread something like that, because I knew we have several hubs around the GTA, for example, and I just wonder, it seems like it could potentially be a good model to try to replicate, but I don't know what the future is for that.
I'm not making any announcements here tonight. That's my minister's job.
I think Carrie has many of the elements right. In my own experience, and I know it's yours too, Nicole, you actually have to get into neighborhoods that have people who are marginalized for whatever reason and figure out who you work with to help them. And, we've done a lot of work. We've done some successful work as a hospital in Thorncliffe Park, and of course we have a failure of trying to deliver a health service to a community that wasn't prepared at all to use it in the way we try to set it up. We try to establish for a part of the city that has very, very high birth rates and high rates of pre- and postnatal hospitalization. Tried to set up a pregnancy clinic that nobody ever showed up to, as you're well aware. It's part of having partnered locally with an agency that we thought could really help us achieve this, and of course the end solution is a primary care one, which make a lot of sense to people. But it really is to find their voices and find the people who represent them if they don't represent themselves, and work with locally credible organizations to find and co-design the solutions that'll make a difference for people. We partner a lot with you, who represent Access Alliance. We also work a lot with South Riverdale Community Health Center. And I would say the thing that I hear all the time in trying to design an integrated health system is don't forget the people who have no voice. And that's who we're trying to represent. And they bring it, you bring it, and South Riverdale bring it always to the table. And I'm thankful to hear that voice, because otherwise they probably would be forgotten.
Perfect.
Sure. I don't have an answer, but I think what struck me when we looked at the evidence, again, for self-management support in particular, one of the key issues that the evidence is so patchy is that the current mechanisms and strategies that exist work well for people who know what they need to do, and they just don't work at all for people who live in very deprived circumstances. And what we need to understand better, as you say, is what are the issues that prevent people from using services or knowing about services, and how can we support in primary care communities in that way. I mean, there are some really interesting examples in East London where where there are high levels, high pockets of deprivation, and where community workers and volunteers are being used, or they've volunteered to act as navigators for some people. But I think what you need to understand first, what Sarah was saying, is to understand what are the issues, where do the problems occur, and what are the most appropriate ways of addressing the types of need. And this will be very locally specific, what works best in those kind of groups and areas.
Terrific. I think we have one last question. Please go ahead.
Hi, good evening, everyone. My name is Victoria Williams, and I work at the Toronto Central LHIN. So as someone who works in healthcare, I recognize that I'm sort of representative or someone from that provider perspective, but I also am someone who's experienced or I'm receiving services from the very same hospitals that we fund. And so in some way I receive services for those chronic issues. And so I guess first I would recognize that there's privilege in being in that provider perspective. I would also kind of like to explore that assumption that when you are a provider, you're not a patient. And so I'm kind of curious to know whether there's been any research around how you leverage providers, not from their provider perspective, but more so like as a patient.
Anybody want to comment? Okay, I'm going to jump in if you guys don't.
There are many providers who, after having significant patient experiences, become reformed.
Ouch. I'll just say, some of us have sporadic, and I think Walter will show that, half of us have $150 of healthcare services a year, and there's some number close to that. It's probably grown a bit.
It's up to about 350 now.
Is it 300? Okay, good. I've missed 4 years, don't forget. I just watched my father go through a profound, experience. He died 3.5 weeks ago, and the transitions were terrible. And I must admit, I have fire in my belly as a deputy minister. That I know that that's what people see, but to be fair, I'm also the daughter of somebody who gets home care. I watched a transition go incredibly poorly. Everybody was doing a good job within their domain, but the handoff, that I had talked about many times, and I'd used Walter's data to actually describe, what those trajectories of care are, and then when I experienced it on behalf of my father, it was quite remarkable, and I guess I'm going to carry that with me, whether somebody says that I'm a bona fide patient and family caregiver or not. It will inform how I approach, the rest of my mandate. So that's my little plug. Yeah, beware. All right, I think with that.
Can I just say something on that, though? I think in my presentation, I didn't want to do provider bashing. I think what is true, many physicians, for example, are very keen to provide more patient-centered services, I think it is quite challenging when you have been trained as an expert to actually take a step back and take in the expertise of the person you are facing, be it the patient or their carer. And there's some really interesting studies that have talked to physicians, and they have said things like, I just need to learn to shut up and to listen. And it's quite difficult when you've trained in a way to be a confident provider, because no one wants to go to a doctor and say like, oh, I don't know. You want to have advice from a physician who kind of is halfway confident. So it is quite, and how do we overcome this challenge, and how do we create organizations that enable physicians, in particular nurses, are more person-centered from their training perhaps, but to enable an environment that allows them to say, okay, you are the expert, tell me what you want to do. And I think there's a whole investment that needs to happen in training and education to allow this sort of changeover to materialize.
Thank you. With that, I'm going to ask Jodine Goldhar to come up and do some closing remarks and hopefully a call to action. So please.
I'm always inspired
by the community that the Dalai Lama School for Public Health and the Institute for Health Policy Management and Evaluation brings together. And tonight is no different. The authenticity of each person who speaks to their experience in driving integrated care really matters. And I know we're joined not just by the people in the room today, but many people joining us through live webinar. And you may wonder why I am being asked to bring closing remarks by Steny. And I want to tell you a little bit about my journey in integrated care and how we are partnering together to realize the potential of integrated care in Ontario. I had an epiphany about 15 years ago in my career. I am a social work clinician. I was practicing in a multi-level health system serving the elderly. And when I was listening to and understanding the experience of people and their families, I really understood that what I could facilitate within the organization I worked with was a very small part of their bigger experience. So I went back to school and I joined the community that is inspired and that is here today. And I developed some of the professional skills around health leadership and system change. And what I realized when I started to facilitate the strategy for that same multi-level health system serving the elderly and their families, again, it was just a small lens, but when we spoke to people and their families, they were experiencing so many parts of the health system. And I made a commitment at that time that I would attribute my whole professional and personal goals to listening, learning, and understanding and working together in partnership to realize the potential of Ontario's health system. But there were some fundamental underpinnings. And the first was by listening and learning from the people who are receiving care and their families and friends and neighbors who are supporting care is our true north. We bring multiple lenses. All of us talked about it today, and our lenses inform our approach to integration. We have a true north. It's the experience of people and their families, which is us, and which is everybody that we support in the health system and the people that support them. The second thing I realized in this journey, and many people on this panel and others who are not in the room helped me realize, is that partnering with people and their families, patients, clients, and their families is relevant no matter your lens. Research, policy, funding, and practice. What's exciting about that is that we are on a frontier and we're learning together. When we started that process and I had an opportunity to facilitate integration for certain complex populations over a 7-year period, older adults with complex care needs and their families, people towards their end of their life, and children with medical complexity, I realized that it's not just in Ontario that we are trying to do right together, but there's a global movement around integrated care. And Ellen spoke to it, and many of us are connected. And we started to participate with the International Foundation for Integrated Care, which brings 54 countries together around the world who are driving integration. So we could learn from each other, so we could look up and look out and connect. And I joined the Change Foundation 2 years ago in a role that helps actually build on the experience and expertise of the Change Foundation, which is to listen and learn from the experience of people and their families, and to bring health system providers, organizations, researchers, policymakers together to see how we can co-design our future, how we can co-design integrated care. And the Dalai Lama School of Public Health, along with the Change Foundation, reached out to the International Foundation for Integrated Care and said, how can we get more involved? How can we bring to bear the 54 countries and the work that's happening to Ontario and to Canada? And we are hosting their first conference in North America in October 2020. And together we decided that there are some fundamental pieces in the design of that work. It'll be co-designed. We will plan every step together with patients, clients, and their families, along with funders, policymakers, organizations, and clinicians. We also made a commitment that we wanted to intentionally leave a 2-year build. We know that in Ontario, we're at such an opportune time to learn from other countries around the world, but also to recognize and build on the incredible work that's already happening in Ontario and what we want to realize in Ontario. And last week, Helen Bevan, the Chief Transformation Officer for the National Health System, was here. And many of us follow her because she is also a bit of a guiding light around how do you come together across policy, research, organizations, practice, and partner with people and their families to create change in a way that change has not always been enabled. And Helen, you talked about the change management approach. How do we build momentum? How do we come together around shared purpose, shared goals, and deliver together over time to build our capacity? And what we're realizing from these discussions is we know the why for integrated care. We're starting to really understand the what, that it's a process moving towards population health. And where we really have an opportunity together is to understand the how. How do we bring out the potential of all of us, no matter where we sit in our health systems, to partner and work together to realize the value of integrated care? And I know those themes were highlighted by every single person tonight, and I am so proud to stand with closing remarks to say that we are in a health system in Ontario that is led through values-based leadership, that we really care about what we can all do together to partner, to build trust, and to build healthy communities together. I'm excited that we're on this journey, and I'm grateful that we partner to do this and that I had an opportunity to say thank you to everyone. For Ellen, for coming in and sharing your amazing experience and advice for us. Great, and to talk about the partnerships that we're not considering, but we have to, because only together can we realize our potential. Sarah, I know you're leading community change, and you're changing the role of hospital. Role of hospital as facilitator, as building trust, as helping realize the potential of all partners in community and problem solving together. Carrie, you don't just bring a voice from your experience. Carrie, I've had a great opportunity to work with for many years, and we partner in some of the work we do now. And I've never met somebody who really just sits and listens and walks a step or two so that she could be in service of bringing a voice to the experience of patients and their families. And to Walter, who I've also had the great pleasure of working with for many years and partnering with, along with Steenie, to bring the conference to Canada, the first in North America. I've watched Walter, he sits and he meets with the teams that are doing integrated care, and he listens and evolves his approach so that he can understand what are the mechanisms, what are the pieces that are intangible that we want to really understand so that we can help build the capacity for integration. And he does it with so much humility, yet he is one of the foremost researchers around the world around integrated care and connected to all the global research on integrated care. And to have the honor to join Helen Angus, our Deputy Minister, who is really looking to enable this change and also bringing her own personal experience to bring to bear on how that can happen. I feel proud and lucky for that. And to Steenie Brown, who is facilitating a lot of the integration work and who enables the community that allows us to come together and realize our potential. I thank you for the opportunity to come. For those in the room, alumni, students, friends of Dali Lana, and to those online, thank you so much for joining us, and we look forward to the continuation. To Les, thank you for sponsoring. It's amazing. I've been watching the Twitter feeds on the Boehm Lectures series. I encourage everybody to look, because when Helen Bevan was here last week, she taught us that on social media, we're generating so many ideas, that we actually have a collective virtual community that we could leverage to support this change, and to provide the venue for that to happen is incredible. So I wish everyone a great night and a good continuation of this discussion. Thank you.